We'll move ahead to the last presentation, that's on metabolic modulation in chronic coronary syndromes. I'd like to invite Dr. Amresh Agarwal, Senior Consultant Interventional Cardiologist at SRMS Multi-Specialty Hospital from Bareilly, to speak for 12 minutes, and then we'll take up 3 minutes of discussion. The timer is straight across. Dr.
Thank
Agarwal,
you, Chairperson and expert panelist, and good afternoon, everyone. I have to speak on metabolic modulation in chronic coronary syndrome. So we have seen regarding the CAD burden, we have seen this in India especially. The CAD tend to occur in younger age in Indians, with 50% of cardiovascular mortality occurring in individual aged less than 50 years. Prevalence of angina increases with age in both sexes, in men as well as women. Regarding the pathogenesis of chronic angina, basically in classic view it seems to be this is due to the demand of myocardial oxygen demand supply mismatch. Either increased supply or decreased supply or increased demand can lead to myocardial ischemia. But these are the major coronary arteries. But coronary arteries are not only these. There are smaller arteries too, and in microvascular angina there is role of endothelial dysfunction is also there. Heart is more than a pump. It is also an organ that needs energy from the metabolism to its proper working, and ischemia is a metabolic disease should be ideally treated by metabolic therapy. This is not only the hemodynamic disease, but this is metabolic disease too. Regarding the heart metabolism, healthy heart draws its energy mainly from the glycolysis, glucose oxidation and fatty acid oxidation. Heart is known to be a metabolic omnivore. Even this can use other substances also like lactate, in certain condition ketone bodies, in starvation even ketone bodies, or even in last amino acid too. In normal condition, in normoxia condition, heart draws its energy mainly through the free fatty acid oxidation. Around 2/3 of ATP from the free fatty acid oxidation and around 1/3 ATP from the glucose oxidation. These are the pathways. Free fatty acid oxidation, and second one is the glucose oxidation. In normal condition generate the ATPs. While during mild to moderate cardiac ischemia, there is a substrate shift. Heart draws its energy mainly through the glucose despite the free availability of free fatty acids, while during the prolonged or severe ischemia, again there is a substrate shift and heart draws mainly energy from the beta oxidation of free fatty acids. And high rate of fatty acid oxidation further inhibit glucose oxidation due to the competitive interaction. During ischemia, we can see there is increased fatty acid oxidation and decrease the glucose oxidation, increased glycolysis. This leads to anaerobic respiration and accumulation of lactic acids, acidosis. We know for the glucose oxidation, there is more ATP generation on the cost of 1 mole oxygen consumed. While in fatty acid oxidation, this generates more ATP, but at the cost of more oxygen consumption. So during normoxia condition, when there is oxygen available freely, then free fatty acid substrate is good, while during ischemia, glucose oxidation is good for the energy production. We can see during ischemia, free fatty acid oxidation has unfavorable effect on the cells, require more oxygen, producing less ATP, more free oxygen radicals, more lactate and acidosis, and further depressing the myocardial respiration, and this lead to arrhythmia, contractile failure, and even cell death too. With this background, we know during normal condition, fatty acid is better, but during hypoxia, glucose is better. So with this background, regarding the management approach of the coronary syndrome, so we know now this is hemodynamic abnormality as well as the metabolic abnormality. So then combined hemodynamic and metabolic treatment is more effective rather than treatment given by hemodynamic abnormality alone. Then now role of metabolic modulators come. Basically what metabolic modulators do, basically these metabolic modulators used for optimize the use of energy substrate. Basically substrate mainly use fatty acids, so from the fatty acids shifts to glucose utilization. And this aim is achieved by either inhibition the fatty acid oxidation or stimulation the glucose oxidation. This can be directly achieved by enhancing glucose oxidation or directly inhibiting the enzymes that participate in the fatty acid oxidation, or we can achieve this by decreasing the free fatty acids available in cytoplasm or in mitochondria. We can see fatty acids and glucose goes from the blood inside the plasma of the cell, and through there by CPT1 and CPT2 it goes inside the cells. So this CPT1 and CPT2 can be blocked by parhexylene or etomoxivir, and this beta oxidation of fatty acid can be inhibited by the trimetazidine or ranolazine. Trimetazidine is the most widely and most extensively studied drug till now, and this act by the reduction of free fatty acid oxidation, this indirectly increase the glucose oxidation. In choice 2 study, there is, when combined with the beta blocker, then this increase the exercise capacity within 2 weeks, and this is persistent up to 6 months. In another study, ODI study, when trimetazidine 80 mg once a daily used, and there was a significant reduction in anginal attack, short-acting nitrate use, and more angina-free patients, improve exercise capacity, better compliance, and high patient satisfaction, and even physician satisfaction was around more than 99%. In another study, modus vivendi study, when trimetazidine was combined with beta blocker, bisoprolol, and other traditional anti-anginal drugs, then there was a significant improvement in quality of life and good adherence at 3 months. Adverse events were rare. This drug, in meta-analysis, this drug was comparable to other anti-ischemic drugs. Other metabolic modulators which were studied, that was the ranolazine. This was an additional mechanism of action by reduction in intracellular calcium overload through inhibition of late sodium channel and decrease the fatty acid oxidation. By decreasing the sodium channel blocker, this decrease the calcium overload, improve mitochondrial function, and finally electrical stability. In multiple trials, in monotherapy or in combination, this drug was proven to be effective in decreasing the anginal attack, improvement symptoms, and quality of life. The other drugs like glucose oxidation, like increase the glucose oxidation like dichloroacetate, but this was the toxic drug and not used now. Other drugs, CPT1 or CPT2 inhibitors like parhexylene, etomoxior. These are not, these drugs are not available in India, but some of patients have hepatotoxic or neurotoxic or neuropathy, so not available in India right now, so not using. Other drug is L-carnitine, cofactor for fatty acid metabolism, but for the prescription need large trials. Other is CoQ, very commonly used by physician, but have several advantages like endothelial dysfunction improvement, antioxidant, decreased blood viscosity, but for further study as warranted for clinical practice. And future perspective, there are substrate, there are transporters like CD36 and GLUT4. These are the transporter responsible for the availability of fatty acid and glucose inside the cell. So in modification, these transporters can be further application in metabolic modulation. So in this is basically not a hemodynamic disease, this is a multi-target disease, multifactorial disease. So multi-target approach should be applied for the patient. First we have to see the patient clinical profile, then we can use the drugs. And this is new algorithm for angina management also encourage personalized treatment, because all the hemodynamic drugs should be prescribed after basal clinical parameters like blood pressure, heart rate. If heart rate high, then calcium channel blocker, beta blockers we can use. If blood pressure high, then calcium channel again, beta blockers. If blood pressure or heart rate low, then in that situation trimetazidine, renologine may be preferred drug. Regarding the guidelines in the management of protocol stable coronary syndrome in India in 2015, there was executive summary. When two hemodynamic drugs fail to improve the symptoms in the patient of chronic stable disease, then we can use the trimetazidine. Regarding the guideline ESC 2019, this is a 2A, when there is a symptoms even after treatment of standard drugs, then we can add on as a second line drug of this. Or if there is a low blood pressure or low heart rate, then this can be used as first line drug. So on conclusion, the take home message, basically chronic coronary syndrome is a hemodynamic disorder as well as metabolic disorder, number one. Number two, so management includes combination of hemodynamics drugs as well as metabolic modulator too. Now trimetazidine and a renologine is a class 2A indication for relieving the symptoms in chronic coronary artery disease. Irrespective of class 1 or class 2, angina treatment should be tailored to individual patient need. In symptomatic patient with angina, trimetazidine, renologine reduces the anginal attacks, improve quality of life and sublingual nitrate need. Thank you very much.
Thank you, Dr. Pandey. I think in one of your slides you mentioned that these two drugs give a lot of physician satisfaction, the cardiologist satisfaction. And very rightly so, because I am one satisfied cardiologist who've been using both trimetazidine and renologine in combination and perhaps as a first line drug for management of stable angina. And a lot of my colleagues would say that you should use it only when the others fail, but in my practice I use it along with the other anti-anginals as first line, and I am a very satisfied physician with their usage. Some of my friends will also snicker and say that why don't you use any Patanjali product as an anti-anginal when you're using these drugs? But I think with experience I have a lot of confidence, and I'm glad that so much of evidence is available, and now these drug usage has gone up to class 2A, which is nearly class 1. Your comments, my co-chair.
I fully agree with what, again, I have been a very heavy prescriber of this trimetazidine. It definitely gives you a very symptomatic improvement as far as the angina symptoms are concerned, gradually improves the ejection fraction. I cannot say that this drug alone is improving the ejection fraction, but in a failing heart while you are using this, gives you a symptomatic relief to the patient. So why not give that benefit to the patient?
Our panelists.
Three of them.
Definitely,
Yeah,
I would
that's
agree
the
with Dr.
time that we have, Mr. Chairman. We'll have to wind up the proceedings with your permission.
Yeah, we will in 10 seconds.
I agree with Dr. Amresh that in patients who are not hemodynamically stable, it offers you a choice to give a drug to that ailing heart and perhaps give you the period to tide over and institute other agents.
So I guess we've got a signal from there. So thank you very much, Pandey.
Thank you, sir.
very much, the
Thank
senior
you.
Pandey,
Thank you.
and thank you very much, Dr. Agarwal, for very kindly, exposing us to the dual pathway inhibition, to the dual antiplatelet therapy.
Thank you very much, chairpersons, members of the
Thank you
expert
very
panel.
much, my co-chair and my panelists.
We move on to the last session, that learn from masters. We've got 5 speakers